So just for members' awareness, our colleague Chris Clark, who is from NHS England, normally attends this meeting, and when he doesn't, we have the pleasure of Dave Eiley. But Chris actually retires after 40 years. So today's his last day, although he officially retires on the 16th of August. So I'm not sure that he will join us again as a member of the public live streaming our PCCC. I'm sure he will, because he'll be riveted to what we have to say. But that aside, we want to formally thank him. I personally have worked with Chris for many, many years, and what he doesn't know isn't worth knowing. So yes, I'd just like to formally thank him and have the notes show our appreciation of his support to the Vale of York. Thank you.
Beautifully done, Steph. And yes, and I think we'd all echo that. We do value our team with us, don't we? So thank you. Right, so moving on, if I start the meeting properly, it's a warm welcome to everybody in the truest sense of the word, I think, because we're all a little bit hot under the collar today. And if I start off with apologies, I have apologies from Phil Metton, Fiona Bell Morritt, Paula Evans, Gary Young, from our Health Watch colleagues, unfortunately, and from Tim Maycock, who's out of office, says he's on a well-deserved holiday. So hopefully he'll take the hint that we're all trying to give to everybody to take the holidays. You desperately need them. And we believe that Sharon Stoltz will be joining us later. So if I start off with declarations of interest, please. If there are any declarations of interest, if you can let us know either now or as we come to each item, that would be really, really valuable. And the next thing will be the minutes of our previous meeting. And I've just made Michelle giggle because I picked up a typo in one of my messages to governing body, which we have hastily corrected. So apologies for that. It was probably computer gremlins and brain not functioning. And then the next bit that I'd like to go to is matters arising from our previous minutes. And I've got a couple of updates. Steph, do you want me to do PCC 54, or do you want to do that for us? I know you kindly sent me an update.
Yes, I can do it, Julie. That's not a problem. So members will know that we have been working on a med safety assurance flowchart. I think that's the action you're asking me about, Julie, is it? I was just clicking through my notes, probably at the crucial bit. So Laura's very kindly updated that as members know, we're trying to align a number of our committees so that we do it once with North Yorkshire colleagues, and then in fact, because Meds Management is a specialist service, wider over the regional patch as well. So the last York and Scarborough Medicines Commissioning Committee occurred in June, so last month, and then the first North Yorkshire and York Pharmacy Committee occurred a couple of weeks ago, supporting the alignment across that strategic partnership that I've just described. And so the med safety assurance flowchart, which is actually the point of the action that we were talking about, that's now been approved by LMC, and it'll go to the next QPAC for the final approval as we agreed. So that's the mechanism by which any of the safety announcers are assured back through practices. So LMC had some particular points on that. So once it goes to QPEC, and it'll come back to PCCC, and that will be that action closed. So I just want to give assurance to the committee that that action continues to progress, and it'll reach a conclusion probably for our September PCC board.
Thank you, Steph. And I think we'd agree from the notes that we're all quite happy with that. It's a real positive way forward, I think, from where we were. So thank you for that. Right. Michelle, is Abby joining us or not today?
I'm not sure.
It's okay because it's.
She did say that you'd done a lot of the actions, so she thought perhaps you could do it.
Yeah, I'm sure I can. Yeah, I just didn't want to start speaking and she'd taken the time out to step in. So we did our and I've forgotten the name of the thing that we did, that the electronic where we answered all of the questions.
The survey monkey.
That's the one. I should do the visualizing stuff, shouldn't I? I've usually got elephants in the brain, not monkeys. So we did the survey monkey, and I think it was a bit strange because for mine I felt it was a bit multicoloured and didn't answer any of the questions. And yet in person, when I asked the question, I think we were all happy with the way that the processes that were part of this committee and felt assured. And I think with all of our committees as well, we were very open to evolving and changing to meet the needs of this evolving world that we live in. And out of that, we were supposed to come up with 3 recommendations for the future. And taking into consideration a lot of the messages that we were getting. So if you forgive me for reading these out and to make sure that I get these right. And Abby and I have worked on these, and I believe that we're in a good place with them. But I'm still happy if you'd like to challenge me on anything that you think is not quite right. So here I go. So it will be around working collaboratively with primary care to support them with the reputational damage as a result of media and other campaigns. And that's been a huge issue recently, and it follows on from our meeting this morning and our concerns as well. Develop a matrix that enables the committee to highlight good practice to the ICS and places during this transition phase. And what we need to think about, what are the fears, the ambitions of primary care in York if commissioned from the ICS. So it's going to be slightly different, and we need to make sure that we're supporting our PCNs through this and supporting PCNs to navigate that transition successfully. So we need to make sure that we're doing what we normally do. We're listening, but then we're carrying through with that conversation. So I don't know whether anyone else has got anything else to add, any thoughts. What I will do is I'll email them around, and you can add anything else to them if you'd like to. Is that okay? Thank you. If I say it's not written in stone, we don't do things that way, but we want to ensure that we set ourselves targets that are meaningful. Right. Thank you very much. Simon, it's over to you. And if I apologise, we're having IT issues at the moment across the whole of the organisation. And unfortunately, that IT issue has impacted on Simon's camera. So he's not here, but he is here. He's just his photo is over to you, Simon.
Yeah, thanks, Julie. Afternoon all. So this is a slightly longer paper than usual. It's covering off a number of specific items. In here, we're describing how we've set the budgets for the first half of the year. That's the first thing to note, is that it is only covering the first half of the year. We won't know about our second half funding until probably September. So how the plan's been set, so I'll highlight the broad themes there. The year-to-date forecast position.
Apologies, Simon. we can't hear you very well at this moment in time. I don't know whether there's any way you can have a look at your sound.
You've gone all Doctor Who on us, mate.
No, all looks good this end.
Oh, it's cleared now, Sam, and it's fine. Thank you.
Okay. So how much did you hear, Julie?
None.
None. Okay. So this is a slightly longer paper than usual. It's looking to cover off normal business, but also a few specific items. So we're describing how we've set the plan for the first half of the year. And I'll pick out the main highlights out there. It is useful to note that it is only for the first half of the year. We won't know what our second half funding is until September. We describe, as we usually do, the year-to-date and forecast position for the primary care finance element of the CCG's budget. And then specifically, we're looking at a recommendation around PMS premium monies and what we're recommending to the committee we do with that. And then also a specific request from Elvington Medical Practice with regard to flu vaccine cost reclaim. Is that okay, Julie? Everybody hear that? Yeah.
Sorry, I was muted, Simon. Yes, thank you.
Okay, good stuff. So the first half of the paper covers off how we've set the plan, and that's largely speaking taking each of the outturn positions across the budgets, adjusting for non-recurrent items to get to the outturn position, applying nationally prescribed price uplifts and activity growth uplifts, and then making any specific adjustments for nationally prescribed investments into primary care, of which, as we know, there are a number. So I won't go through those in detail. They're all set out in the paper. The main area of difference is around primary care prescribing. What we've done there is to remove the activity growth. So we increased that budget by £178,000 in line with nationally advised method, but we've removed that growth because the financial position of the CCG, as has been reported elsewhere, was such that we needed to achieve additional savings in order to produce a break-even plan. So there is an expectation around primary care prescribing that QIP will be achieved in order to bring that budget in on balance. And Laura and the team are working on that, and have got some plans in hand around that. But we'll have to wait and see a few months more to see how that's working. Because we've only got 1 month's data so far. So that's the plan. Year-to-date and forecast positions, we're at month 3 now, so within the overall context of the CCG, which has forecast it will break even for the year. We have a month 3 position slightly under for the delegated budgets, and slightly over for the other primary care budgets, the main one there being primary care prescribing, which wouldn't be unusual at this time of the year whilst we're working on the savings schemes. But overall, it's broadly in balance, and we are forecasting that overall the position will come back to, give or take, balanced at the £58 million total budget. PMS premium monies, the delegated budget includes £313,000 in relation to PMS premium. This allocation's got to be used to benefit all of primary care, and is distributed as determined by the CCG. And not dissimilar to previous years, we've done that by looking at the relative list sizes across the practices, grouped together as PCNs, and that's set out in the table in section 4. And what we're recommending to the committee, so what we need to take a decision on, is that we distribute the monies to the PCNs per that method, per the table set out there, with a request that PCNs work with the CCG to develop plans targeting specific areas for investing that money. And the primary care team and the STEPS leadership will be working with practices and PCNs to agree mutually what the areas for investment should be and how that will be reported on. So it's probably worth pausing there, Julie, just to take some views rather than me go on then to the Elvington issue. So happy to take any questions on the plan, the year-to-date or forecast positions, or the PMS premium distribution. But the specific question is around the PMS premium distribution.
Thank you, Simon. Yeah, that does make good sense. Any questions or comments for Simon? No. I think it was a really good report, Simon, and it was. Sorry, did I hear somebody then? No. Okay, sorry to go back. Yeah, it was a really well-written report, easy to understand, Simon, and makes complete sense. Thank you. Yeah,
not my efforts, Julie. That's Caroline Goldsmith, who's the CCG's finance lead for primary care. So all credit to Caroline. I just get to read it out.
Well, huge credit to Caroline there then. Thank you, Simon. Okay then, and if you'd like to go on to the Elvington bit as well, please.
Or did we want to pause and take a view on the PMS premium distribution?
It looked like you got a resounding yes from.
Oh, did we? Oh, okay, so that's fine. Sorry.
Sorry, Simon. I'm forgetting that you can't see us either, can you?
I can, but I was looking at the report, which doesn't help.
Actually, no, it's good you're looking at the report, isn't it? No, thank you.
So
yes.
That's good. So we can Steph and the team can work on that basis. That's great. Thank you. So Elvington flu vaccines is an interesting one. So it's set out in section 5. So we were contacted recently by the practice to say that they've not claimed for their flu vaccine program for 3 years. Claims process is set out there, but somebody left the practice, didn't tell the new person coming in what they needed to do, and it wasn't until I think it was a GP coming into the practice observed that reimbursement hadn't been made, that the error was picked up. So the missing payment for both the cost of the vaccines and the associated dispensing fees. They are supposed to submit claims within a month, and the relevant authorities confirmed for us that they haven't been claimed for those years, and it is at our discretion as a CCG to make a decision on this on the practice's error. It has been corrected from now on. The prescribing costs borne by NHS England, the CCG is responsible for the dispensing fees, and relatively those are 32,000 and 9,000 respectively. NHS England have confirmed they're happy to cover the prescribing cost in total, so for the full 3 missed years, and we did know about this last year, so we did accrue for the full £9,000 in our outturned financial position last year. So we have the means to pay for this without impacting this year's financial position. We have paid late claims for other things previously to other practices where the practice has shown reasonable and extenuating circumstances. It is at our discretion, however, so we could say no and pay none of it. We could pay all of it, or we could take a view that we wanted to pay 1 or 2 years. We've kicked this around between Steph's team and my team. It's fair to say it's been going around for a while. We've been back and forth over this, and there are different views. But I think the broad consensus is that it's right to pay the practice for all 3 years, and that based on the principle essentially that the practice has done these things. Work has been undertaken, vaccines have been issued, costs have been incurred. So there's no dispute about that. We have had to estimate the exact reimbursement. That's our calculation. It's not the practices. We've based that on best data of the total number of vaccines and dispensers and average costs, but it is our calculation rather than the practices. So that's the recommendation. We think we should go for the full 3 years, but again, it is for the committee to debate and be comfortable with that.
Thank you, Sam. Questions or comments to, I guess, Simon or Steph, really? Bill?
Yeah, my view is if we're going to pay at all, then let's just pay the full amount. Let's not mess about with and trying to come up with some sort of spurious formula or way of deciding why it should be some years and not others, or why it should be not the full payment. I think the only thing is it goes out with a message, the old military thing about prior preparation and planning prevents, and you know the rest of it. But yeah, pay the lot.
David?
Yeah, I agree. I mean, I think, I'm sure they're very embarrassed by the mistake. And, in the current circumstances, what else can we do? Just let's pay it.
I think we've got a unanimous decision there. It's common sense. It makes sense, and I think that the teams have done everything they can to the foresight to actually put the money aside, but also to discuss at great length, because I'm sure it did go around in circles for a very long time. But yes, the consensus I would say was pay it and pay the full amount. That would be our recommendation. Thank you, Simon.
Okay, thanks, Julie. And I think that was it from me. I think, Julie.
Sorry, I just realised I'd muted myself again. I'm trying to negate background noise, which is my fan blowing like a cyclone. Steph, it's over to you, please.
Thanks, Julie. We presented for the committee's review a full dashboard. Is that where we're at? Because I'm flicking between agenda. Right, great stuff. Thank you. So again, in the same vein that Simon took, this is none of my work. Sean's going to present it. As I say, this is the full gamut of the information that we have to date. So we normally bring an extract or share things, but this is an attempt to bring forth a consolidated picture of the data that we have. And Sean's worked with George Scott, particularly from Simon's team, and I wish I could interact with Bill Pate, because this was something that he regularly championed us to do, and so it falls into that context, and I hope to be able to have an offline conversation with Bill, because I enjoy our interaction. So without saying much more, I'll hand over to Sean.
Thanks, Steph. So yeah, I was just going to go back. This has been a bit of a journey over the years, but as Steph explains, it was something that was started by Bill McPate, who quite kind of rightly asked, how does the committee assure itself around primary care quality? We've been through a couple of iterations of this dashboard. some of the national data isn't particularly timely. You know, there are challenges around the data that's available. We kind of went through a process of trying to review the data and the report pre-COVID with Dr. Aaron Brown, who was working with us at that time. And then I think with COVID happening, things took a bit of a pause, but we have recently managed to kind of reinstate this work. So I'm going to walk you through what is kind of the first iteration of the revised dashboard. So I'm going to try and share it on my screen through Zoom. And I've got my narrative on another screen, so forgive me if it looks like I'm looking over the top of you, but I'll just walk you through as best I can. So I'm not going to go through the narrative because I'll effectively, the format of the dashboard is we'll put an executive summary at the start with the highlights, which I'll just take you through now in relation to each of these screens. So I can only see a limited number of people down the side of my screen, so shout if you want me to stop and explain anything. So we'll start off with a population. This is useful. It doesn't change that rapidly, but it just gives us an idea of the sort of population profile of the CCG by age band and by gender. Another interesting factor is how our practices are positioned in terms of their deprivation scores. And we do have one practice, which is in the third quintile. So that'll be Scott Road, where we know that there are areas of deprivation down in that area. Now, broadly speaking, you know, we know that most of our practices are not in particularly deprived areas, but we do know that there are pockets of deprivation across our geography. So that's something to bear in mind as we go forward with our planning of services. Moving on to the sort of Quaff and disease prevalence type information that's available to us. So this has a bearing on sort of what practices do around long-term condition management and reviews. And it's also a good pointer for the work that we're looking at in terms of population health management specifically. And this gives us an idea as to how the CCG is doing compared to the England average with these Quaff reported prevalence rates. Now, you have to take this with a bit of caveat in terms of these are recorded prevalence rates. So it is dependent on the practice of sampling and recording these conditions accurately and comprehensively. But I think when you look at our position in relation to the England average, we're broadly there or thereabouts. There are a couple of areas such as diabetes and depression where the CCG prevalence is a bit lower than the England figure. And I would suggest that's probably underreporting rather than we're particularly good in those areas. But it does give us a little bit of a pointer into where the high prevalence areas are. So we know that cardiovascular is an issue. We know that we have some challenges around respiratory type conditions. Lifestyle and obesity, we know we need to address that, and there is work underway to do that. So following on through the Quaff data, we come through to our practice Quaff performance. Now this is, again, gives us a feel for how our practices are doing in relation to the national average in terms of their Quaff completion and performance. And I think you can probably see as you read across, the Vale of York CCG figures are very similar, if not better than the national average in most areas of Quaff. Quaff is optional for practices. They're not mandated to do Quaff, but it is reimbursed financially if they do their Quaff work. So it is, you know, the best thing that there is in general practice really for incentivizing practices to do that work on long-term condition reviews and chronic conditions, which is, you know, again, really helpful in terms of population health type stuff and prevention work. So I think reading across those charts, there's nothing particularly sticks out in terms of Vale, of your CCG's performance. In hypertension, we're actually quite a bit higher than the national average, but in most other areas, we're probably there or thereabouts in relation to the national average. So I'll just take you through to the next one. So in terms of quality, I think CQC is always a good independent kind of in terms of how our practices are performing. The review process has changed, obviously, over the past year with COVID, and it's a lot less hands-on now, but I guess the majority of these reviews were probably done prior to COVID. And you'll see we have one outstanding practice and all the rest are rated good, which I think is, you know, to all credit to our practices, that's a really good position for us to be in. We've got 100% of our practices that are rated good or outstanding. And that's compared to a national average. About 95% of practices are good or outstanding. So Haxby is the outstanding practice. And the domains that are looked at by the CQC are the practices safe? Are they effective? Are they caring? Are they responsive to people's needs? And are they well led? So still on the theme of sort of patient experience and quality. Sorry, I've gone too many screens up. I'm just going to have to flip back there. There we go. Patient experience is measured through friends and family. So the latest figures were Feb 2020. And our figures show that 76% of patients will recommend their GP to a friend or a member of their family. The national figure is 90%. So we're a little bit below the national figure on that patient experience measure. The GP survey, the Ipsos Mori GP survey results have just been published. And our results show that we've got 83% of patients with a good experience, very good or fairly good experience at the GP practice, which is the same as the national average. 64% found it easy to get through on the phone. That's compared to 68 nationally, so we're below. And 77% of our patients reported that they felt that they had enough support to help manage their conditions, compared to 74% nationally. So I think that kind of paints the picture that the patient experience and the view that they have enough support to manage their care is generally good. But as we probably already know, the recurring theme is that access through to the practice, and particularly how easy it is to get through on the telephone. So there's definitely some work to do there, which I think we're aware of and working on. So we've got a couple of specific slides around health checks, which are interesting because the SMI health checks, physical health checks, and the health checks for people with learning disabilities have been national targets last year and this year. Performance on the SMI target could be better. I'm just reading the figures. 30%, so for last year, Q4, 30% of people with severe mental illness received a complete list of physical health checks in the preceding 12 months. And that's below our local target of 45%, but it's quite a bit above the England rate of 23%. So again, we haven't hit our target, but compared to the national average, we perform relatively well. SMI is part of Quaff this year, and we are doing a lot of work with practices to try and increase that offer of those SMI health checks using different ways, outreach, that sort of thing. So we're hoping that indicator will improve this year. We put a lot of work into the learning disability health checks last year, where the national target was 67%, and we actually achieved a CCG position of, it was just short of 80%, which is really impressive because we were really struggling with those learning disability health checks throughout the year. So all credit to our practices. I think they put an enormous amount of work in over the year on those LD health checks and really turned that position round. So we have a trajectory this year to get us back up to that national target and beyond. But as you can see, we've not quite met it in Q1, but we do expect the performance to pick up over the year on that one. Just a quick run through in terms of immunisation and screening. Again, I think we perform pretty well in terms of childhood IMS. The CCG figures are all higher than the national levels. The lowest uptakes are the preschool boosters, where we've got 90% uptake compared with a national uptake of 85. So even though that's our lowest, we're still above the national average. The seasonal flu, we've got an uptake of 84.8%, which is higher than the national. Cervical screening for 25 to 49 is 69%, and for 50 to 64 years is 76%, and that's higher than the national average for both groups. And then the vaccine of the moment, obviously, is COVID. So at the end of June, our double vaccinated rates were over 90% for the 50 plus age groups. So we've done a huge amount of work on supporting our vaccination centres and our practices with the COVID vaccination programme over the past year. And it is really good to see that the success of that programme in Vale of York, we're doing really well. And I think that's recognised regionally and nationally. And it puts us in a really good position going forward to sort of September with the work around the boosters that we've got coming up. So we've got a bit around workforce as well, which gives us a little bit of insight into how our general practice workforce is looking. So in terms of, this is measured in terms of whole-time equivalent staff per 100,000 registered patients. And we're higher than the England average in all the different staff groups. And interestingly, we're quite well GPs. You know, we have 67 GP whole-time equivalents per 100,000 patients, compared with that national figure of about 56.4 nationally. So although we're under a huge amount of pressure at the moment, we are quite a well-doctored area, and it's an attractive place for GPs to work, which is encouraging. There's a lot of work going on at the moment, as you probably know, through the primary care networks around additional roles, recruitment. The chart at the bottom left just gives you a view as to how many additional roles we've recruited to date. So 20 odd clinical pharmacists, 13 social prescribers. We've got physios in there, pharmacy technicians, care coordinators is a new role which is having a big impact. So I think that gives assurance that we're recruiting quite well against those additional roles, and they're starting to find their place in the general practice workforce, and broadening that skill mix, which we're working towards. There's a little bit in there around retirement age staff. So again, we're under the national average for those, but it's something that we just like to keep an eye on in terms of potential retirement issues with areas of the workforce. So if I just now move to primary care appointments, this is obviously a very topical one at the moment with access to primary care, and a big change in how appointments have been offered through the pandemic, and particularly the lockdown. You can see in the top left chart, there's a big dip around April, May last year when lockdown started. But you can see that, general practice recovered August, September last year. And broadly speaking, as of April, May is fairly similar to April. It's just been published. We're broadly back to pre-COVID levels in terms of the numbers of appointments that general practice is offering to patients. And I think that's a key kind of indicator at the moment around access to general practice. Although we know the problem is that even though access is back to pre-COVID levels, demand is exceeding that capacity at the moment, and that's partially the reason that patients are having some issues getting through on the telephone. So Related to that is some of the work that we're doing around digital in order to broaden the access channels for patients and to take some of the load off the practice telephone lines. So we've done a lot of work over the years in terms of promotion of the NHS app so that patients can, book appointments digitally without having to phone the practice. They can order repeat scripts and check their record. And with the NHS app, we're way above the England average in that position. And similarly, we've done a lot of work with practices and patients around registering for those online services to book appointments and order repeat prescriptions. And you can see from the charts there that we're significantly above the national average for most of those sort of digital access services as well. And then we get onto some of the secondary care data, which we'll probably expand on a little bit in future dashboards. But this gives us a little bit of a insight into obviously how referrals have changed over the course of the pandemic and the activity that GPs are referring into secondary care, and also some of the data around how outpatient appointments have changed. And you can see in all of those big changes in the run charts, April, May, June last year. And you can also see the one which is kind of significantly different is how the hospital's now delivering outpatient appointments, very much more in a sort of non-face-to-face way through video consultations and telephone type consultations since sort of April last year. So that's a major change. And then I think this is the last slide, just to look at admissions and elective admissions. And this just gives you a little bit of insight, really, I think, into some of the backlog in the acute sector, which is pushing back out into primary care. So while we're doing all those waiting list catch-up initiatives in the acute sector, a lot of those patients are being managed in primary care while they wait to get in for their secondary care procedures or operations. And it just gives you a feel for some of that capacity constraint within the secondary care, which kind of backs up into primary care and puts additional load onto our practices. And then, another area which is really topical at the moment is how our emergency department is coping in both York and Scarborough, and a real kind of tension almost, I suppose, in terms of the demand across the emergency department, the urgent treatment centre and general practice. And that's indicative of all of those settings being absolutely, overwhelmed at the moment with patient demand. And we are working really hard with all of those kind of system partners to try and understand how we manage that demand better collectively. It really does need a joined up approach between the urgent treatment centre staff, the ED staff, general practice, out of hours, to try and figure out how we manage that increased patient demand in the context of rapidly declining staff numbers at the moment as well, with a lot of staff having to self-isolate or they're sick with COVID at the moment. So lots of system pressures at the moment. So I'll stop sharing now because that's the end of the presentation, and happy to answer any questions.
Thank you, Sam. And I think it was good. We hear the narrative, but to actually see it presented in such a way as well just adds that real powerful element to it, and beautifully articulated. Thank you. Any questions for Sean, please?
Sharon and then Andrew.
Lovely.
You see the hands.
I can't. I can see live hands, but with no hands technical. Sharon.
Hi there. Thank you, Sean, for that report. Really, really interesting to see all of that data. So, please pass on my thanks to the people that were involved in compiling that.
Thank you.
I just wanted to raise an issue that Steph will be aware came up at the Health and Wellbeing Board yesterday evening around primary care access. I mean, we all understand the perfect storm that we're in at the moment, with rising demand and strain on resources across the system. As you've explained, you know, staff self-isolating, etc. Is really difficult at the moment. Now, I suppose one of the concerns that was raised on the back of the Health Watch annual report that was presented to the Health and Wellbeing Board last night was the difficulty that some patients are having in accessing primary care. So the digital journey works very well for many patients, but it doesn't work for all. And I think in your slide, you talked about, you know, 64% of people are able, say they can have good access by phone, but that leaves quite a sizable percentage that are saying they haven't got good access by phone. And so there was just a bit of a concern really around how we can work as a system to try and support primary care around this, with a real worry that we're going to exacerbate existing health inequalities. And that is probably, you know, the most vulnerable in our society, who may be either suffering from or at risk of developing particularly long-term conditions, with people with learning disabilities or other mental health issues might be struggling to access. And so rather than looking to GP practices to try and solve that problem on their own, given all of the issues that we're aware of, I mean, is the CCG looking at this at all? Have you got any plans in place to kind of start having those maybe tricky conversations with the whole system about how we can better support primary care?
I think those conversations are happening all the time, Sharon. The digital point is well made. It doesn't suit everybody, but we know that if we can shift a proportion of the contacts across to digital, it frees up the phone lines for those people who are struggling to get through on the phone. So that's kind of the first point, I suppose. We're working with community pharmacy to try and move some of that demand out into the community pharmacy sector, particularly the minor illness stuff and the self-care type stuff, which could have a really kind of big impact. And we are regularly talking to our partners in ED and out of hours in terms of how we try and balance that load across the system. And I think, you know, particularly with the additional roles, the care coordinators, you know, that gives practices another opportunity to link into third sector services and those other support services in terms of trying to manage that demand, not all of which will require a GP consultation or necessarily be of a clinical, you know, nature. I think it would probably be fair for me to say that we're seeing a lot of mental health presentations coming through, and access to mental health services and support it could be better. But I think, yeah, broadly, there are a lot of conversations, Sharon, but if anybody else is happy to get involved and give us some more kind of opportunities to work together, I think it would be very welcome.
I think for me, very much it is a system thing, and especially as we're moving forward, it is a system thing. So it is good at any opportunity if we seize that to work together. And I know our comms team have done an engagement team have done a huge amount of work and worked closely with Health Watch. And we talked this morning about our practitioners, the new roles that we've developed and how pivotal they're going to be in enabling the PCN to survive, I guess, through the expertise that they bring in a different way and added value. But it is difficult for those that don't have computer access, that live in rural locations where access to the internet fluctuates and is poor quality, etc. But it is that working together, I think, that gives us our strength. Steph, I'm sure that you've got.
Yeah, I'll invite Andrew to come in, and then maybe I'll add some additional points to what Sean said.
Thank you, Andrew.
Thanks. Thanks, Sean. That was a really, really good presentation. It's great to see this kind of, it's just seeing the data there is so much different to just kind of knowing what's going on. So I guess the first thing I'll do is I'll just come back on Sharon, if that's okay, just her point there. So there's obviously, because access is this word that's used all the time now, and access is great and access is really important, but you can only have access if there's sufficient capacity to have access to. And we need to still be honest about the fact that there is limited capacity, or there isn't the capacity to meet the demand, as Sean said. And so obviously the online and the digital side is all to relieve some of that pressure on the phone lines, which is great, and it's really important. And we've really tried to publicize that within our practice, and we've now moved to Clinic, which is this AI software that I think we've discussed in this meeting before, and that's a way of patients accessing us without having to wait on the phone. They'll get a response from us within 48 hours, and we've been doing all of the work that way. There's still a real problem with that I cannot tell you how many of those consultations are coming through on Clinic, but they've been filled in by a member of our call handling team while on the phone to a patient who could have gone online but didn't want to. And so there is a strong preference still from the whole patient population. There is a cohort of that population who you can offer all the online services that you like. They would be able to use it, and for some people it isn't about inequalities or anything. It's just they're just preferences to go on the phone, and they'll continue to put that pressure on the phone line. So if one way of doing this might just be something just to more widely publicize the benefits of using the online side, rather than it inevitably being presented sometimes as this is a way for us to relieve pressure on our phones. This is the benefits to you. So I don't know whether the CCG can do anything there. And the other thing I was just going to say on that note to Sean is that we've been thinking at the LMC about how to try to capture some of the online work, because obviously appointments are appointments, but you need to meet a certain threshold to get an appointment. And again, from my experience and the experience of the constituent GPs that we represent, we're doing so much work that is coming through as online consultations that isn't an appointment, but it's getting the job done. And that's another part of this kind of limited capacity that I don't think is quite as well accounted for, and I think it's really hard to account for. So I guess I just wondered, and perhaps Sean, we could talk outside this meeting as well, because we are really seriously thinking about how we capture this. But for those practices not on something like Clinic, have you come across any ways of more convincingly capture that? Because at the moment I would describe it as kind of invisible work, but there's loads of it. But these are all really important conversations. And Sharon, from the LMC point of view, I'm never here to make excuses, or I hear what you're saying. I'm a patient, I'm a relative of patients. I want access to be as good as possible for people who can't use the online stuff. But I think these are the real challenges to it.
So if I can just come back, Andrew, in terms of how we might count things better. We're just coming towards the end of a national exercise, which is called GPAD, GP Appointments Data, where every practice has had to map all of its appointment types across to a national standard, which I think is really helpful. I think I need to understand whether that actually captures all the work, though, or whether the standard appointments don't really pick up a lot of this digital stuff. But yeah, more than happy to pick up a conversation outside the meeting in terms of whether we can do anything, because I think you're absolutely right that as we move to platforms like Engage, Consult and Clinic, there is a whole load of work that practices are doing in terms of meeting the needs of patients via that online channel, which are probably not counted with the traditional appointments. So if you look at that chart, which I showed before, the actual number of patient contacts rather than appointments is probably a lot higher. But as you say, we're still in the position where the demand is outstripping the supply at the moment. So it is difficult for everybody. I agree. Yeah.
I wonder whether because Clinic obviously provides an opportunity here that some of the other online consultation platforms don't. So I wonder if there is any kind of way of looking back at the months for which you've presented data for those practices who have used Clinic or something that really does capture a lot of the online stuff and just kind of compare it. I don't know. We'd be happy to share our data.
Yeah, thank you. I'll contact you outside the meeting and we'll see if we can look at that. It might be worth bringing something back to this committee just to give a bit more detail on that and the breakdown of appointment types versus which clinician type they've been seen by, just to give us a feel for how that's mapping out.
Thanks.
Yeah, thank you.
Thank you, Gus. I think that would be invaluable. Steph, did you want to add?
Yeah, thank you. So it'd be remiss of me not to make the distinction between demand and need, because they're not the same thing. And actually, as a community, we want to move towards understanding the resources that are required for the needs of our population. So some of the data that you saw highlighted that we know that we are underdiagnosing, therefore under-treating diabetes, for example. So that's a piece of work that we want to do. But certainly the COVID work that we've done has really brought into focus how we understand and how we engage with citizens and patients. And it's not universal. So some practices will tell you that they have little or no, on the whole, issues with patients accessing services. Routine appointments are running at sort of 2 to 4 weeks, which are longer than maybe they were pre-pandemic. But what we know is that it is different and it changes, particularly at the moment based on staff availability, staff absence, staff willingness to do more hours when they're fatigued. But what we do know is when we did that work around contacting patients in practice for vaccines was big numbers where we didn't have contact numbers for them that were up to date. So when we talk about communicating with citizens, communicating with residents, we do have to be mindful about how we get our messages out there about the way in which accessing practice resources is changing. So the shorthand is that we talk about GPs, but actually our additional roles and the wealth of additional professions within practice that are the right people to see for conditions is something that I think we need to do more of. And Sean touched upon the work around community pharmacist referral service. So that whole agenda of self-care, but also accessing other professions. So I think you're right to highlight it, Sharon. There's more work to do, and particularly in the York Alliance, I hope that we'll be able to have a rich conversation around that, as well as through the Vale system partnership working groups that we have in place.
That's lovely, thank you all. Have we got any more questions or comments?
Julie, I'll just come in. So I can't seem to get the raise hand function going on Zoom. But just in terms of digital inclusion, I know that Christian Turner has headed up a Humber Coast and Vale digital inclusion group across the ICS quite recently, and certainly digital inclusion seems to be coming up in more conversations, and is becoming sort of in everybody's consciousness whenever we're discussing primary care and sort of digital services. And there's pockets of things going on across the patch. So in Bridlington, there's a trial for sort of like a community hub where patients can go into community settings to do video consultations or submit an online consultation when they haven't got access to sort of digital themselves. And it's just interesting how much more we're learning about it. You know, just because people have a smartphone doesn't mean they can afford the data, and it's understanding all that. And there's a practice in North East Links, Roxton, who have done a piece of work to map and assess their patients' maturity so they can tailor services towards it. So we'll hopefully get some learning from that. And we've had a conversation with the NHS England national team about whether that could then be embedded into the GPIT operating model and actually funding for practices to support that. So I think there is more and more work going on. But Andrew and Sean, I'd be happy to join you to have that conversation around sort of OC usage and the softer data rather than just the sort of the obvious contacts. And it might be we can find some support through the digital primary care programme, because I'm absolutely convinced that it can work really well, online consultations. I just don't think it's always started as well in some practices. But it sounds like with Clinic you can embed it really into your access model, whereas some products just seem to get added on the end and not sort of embedded in business change. So there's a work to do, but I think there's a lot of good work and conversations going on.
Thank you, David. That sounds invaluable. I think if we can just keep on joining the dots, and the more information that we can share, and the more innovative ways of engaging with our citizens is the way forward, isn't it? Steph, it's back to you, please. And
yes, indeed. Thank you. That's the risk register, and I'm going to invite Sean because he actually authored the report today, and I'll do the PCN updates after.
Lovely, thank you.
Sean's still on mute.
Yeah.
Sorry, I'm just looking for the risk register report. I've got it here. Sorry. Now I can't see you while I'm reading through this. So again, please shout if you want to ask anything. So currently we have 4 risks on the Primary Care Commissioning Committee risk register, which I think are appropriate at this time. And some of these link across to the dashboard that we've just talked through, quite reasonably. So the first is the learning disability health checks. So we have a national target on this. We feel as though we do have some work to do with our practices and as a system to perform better on these LD health checks. They are challenging for practices in terms of how they perform these health checks and engage with our population to make these a little bit more accessible and successful. And broadly speaking, I think that the plan is that we're working with primary care networks as a conduit for trying to address this gap. And we have agreed some project plans for transformation of these. Sorry, I'm getting confused here. I'm talking. This is SMI. So SMI is going quite. Sorry, this is LD. This is the one where we achieved the target last year. And again, it's just a case of working with the PCNs to keep that on target. The serious mental illness health checks are the ones where we're underperforming. And the report on that is that we've got various initiatives. We've got some dedicated healthcare assistants to work alongside care coordinators. So this brings in those additional roles again, social prescriber link workers and mental health and voluntary sector partners. We're looking more at outreach work to engage with patients with SMI who may be reluctant to come into a practice for their physical health check. We've got a dedicated mental health social prescriber link worker for York. We're doing health checks with healthcare assistants and nurses, which are outreach, where they can go out to patients' homes or their community settings. And we're starting to develop personalised care plans with some of the wider kind of health support initiatives in there, in terms of fitness programs and weight management for that cohort of patients. So trying to not only support around the mental health issues, but also, you know, the physical well-being related to their health checks. The next one is reputational damage, which we've touched on as well in the meeting. And I think it's fair to say we're doing a huge amount of work around comms and engagement with the public. And we've had some really good support from representatives across general practice and the LMC, and in particular Dr. Brian McGregor, who's done a lot of work for us, Dr. Abby Brooks from Priory Medical, who have kind of given us that kind of clinician support that we can use to explain to patients how difficult it is on the front line at the moment, and to try and get that message across. Again, we've got the data on the appointments here that we've already kind of talked through in terms of what's driving that. And then Abby has a risk around general practice wellbeing. So again, this is around workforce wellbeing, not only in the context of COVID and self-isolation, but the pressure that general practice has been under, all system partners have been under over the past year or so during the pandemic, and just trying to do something to support our clinical workforce in terms of how we can ensure that they're as resilient and supported as they can be. And I think Abby was trying to explore a few ideas around how we might support them going forward. This has been to governing body for discussion. The CCG is hoping to form a working group to sit under this committee, just to talk about what might be able to be delivered to support that staff workforce issue, potentially mutual aid, you know, across PCNs or system partners, and potentially we were looking at a PLT session, which could certainly address general practice workforce wellbeing. And I know that the LMC is doing a lot of work around kind of peer support and practice wellbeing at the moment as well. So that's just a quick canter through the 4 risks that we've got on the risk register at the moment, and we'll continue to update those and bring them back to future meetings.
Sorry, I couldn't unmute. Yeah, following on from that, I've been speaking to Abby this week, and I think we've got an offer of a free webinar for our GPs, so that would probably be part of it, which is excellent news. We've got a volunteer who's agreed to test the decompression sessions that we've previously talked about, so to see how good they are for our GPs. And it will just give them that little bit of confidentiality and confidence in a safe setting to enable them to decompress, really. Very much, I guess, on the line of our military, when you think of what they've actually been through, and you know, over the last almost 2 years now. And there's the same organisation that's offering us those interventions. Is also able to deliver something for staff as well, because we talked about our staff having a barrage of, I guess, abuse, and it's how we enable and assist them to keep well and healthy and, you know, and working. So there's begun to be quite a raft of work going on. Any more questions? Sorry, Sean.
I just said thank you. I was just going to mention, I suppose, you know, talking about the system pressure, we're poised to go into what we're calling phase 3 of the COVID vaccination program as well from September, along with flu jabs. So it does feel as though the workload and the demand is going to be pretty relentless through this winter. So I just think it's really important that we, try and do what we can throughout, the next 12 months, probably getting to the other side of the winter and flu season to support colleagues on the front line. Yeah.
Absolutely, thank you. Comments or questions for Sean? No? Thank you, Sean. Steffi, it's back to you, please.
Yep.
So
I'll do an update on the PCNs, although I'll keep it brief because I think you've got an overview of just the breadth of the work that both practices and then the PCNs that they are part of, just the breadth of the work that they are focusing on. So clearly vaccinations is still a focus, and we're progressing with that. We've had a particular focus on making sure that we're adapting our offer to make sure that people in wards, particularly in York, who had low take-up, that we understood why there was a low take-up. And that was a combination. Some of our wards in York have a very young population, similar in Selby, less so in other Vale areas. So we've been working with the practices and the PCNs just to make sure that offer is as easy to take up as possible. So the PCNs have continued to do that work, and as Sean indicated, we're now working with them as we come. Sat behind all this work are contracts that sometimes don't have all the information attached to them to allow practices and PCNs to respond in a timely way, and that pretty much is the case with the phase 3 booster campaign. So we're just waiting for both additional information about flu campaign and over 50s, and sat alongside that the booster campaign for vaccines. So as a CCG team, we're working with PCNs around both of those things. We've touched upon the additional roles. So the additional roles is something that sits in the contract around primary care network. So that's a 5-year directly enhanced service contract. So we'll be working with practices and PCNs on new recruitment, and the PCNs have been putting in their plans for that. So really good examples of innovative working with seldom heard groupings. So just to sort of talk about that in the round, the additional roles are having a big impact, and PCNs are driving that. Again, in the context of demand and need, PCNs are working with all system partners to understand urgent care transformation as it relates to the services that we've developed, and we've got different solutions in different areas now. So just to highlight to committee members that urgent care transformation with system partners is continuing to take place at both a City of York level with the 5 PCNs, and different solutions for our northern locality with the Shah PCN, and our south locality with Selby Town and Tadcaster and Selby Rural. So just continues to be really busy, working through how we flex to work programs. So things like the community diagnostic national program, PCNs have been working really hard on, and yeah, just a really busy time for PCNs, looking at those system changes that are required, that we've already talked about, how you change the improving access contract, how you deliver more when you work at a different scale for those community diagnosis activities. So yeah, just really a lot of work going on. Fiona and Gary, who would normally join us as the PCN lead officers, are actually been in the North Yorkshire and York GP collaborative group. So committee members are aware that the CCG as a statutory organisation is part of the reorganisation of health. So the CCG as an organisation will cease and we'll see something else emerge, and part of that will be a GP provider collaborative, and they're just working through how that big group of professionals and the way in which they organise themselves make sure that their voice and their place in the system is understood and reflected in any change. So Gary and Fiona are at the first meeting of that North Yorkshire and York GP collaborative forum. So that's why they're not here to do that piece of work. So and I'm sure that they would have given you a much more granular response to what the PCNs are doing, which we'll look forward to on the next at the next meeting. So I'll pause there on PCN updates. Are there any questions? No. So just a quick update on where we are with numbers for the vaccination programme, and I'll just give my 3-minute sort of advance warning to Sharon to maybe do the COVID update with so the Vale of York has around about 303,000 citizens in its cohort. So we're looking at a total of first doses of almost 85%, second doses 66%. I mean, those numbers are quite high because of the greater number of older people in the Vale part of our patch, and as you will know, they were eligible for their vaccines much earlier. Our second dose vaccines are at 67%. So really kind of getting up there, and those levels are really quite high. In the city of York, we've got quite a young population in key wards. So if you think about the university students in particular, they became eligible sort of early June, mid-June. So those numbers were low and then increased really quickly. But of course, you're not eligible for your second dose until 8 weeks after. So that's what's keeping our second doses low. But we are sort of, as you've heard me previously say, just continuing to look at where there is low take-up. So that can be at ward level, my language, cohort level. So any sort of grouping that you can be in. So where you live, maybe your ethnicity, maybe there are other characteristics. So we're working with faith leaders, we're working with other groupings. We sometimes take our lead from the national government, which is asking us to consider vaccine in nightclubs, which we think there might be difficulties with consent. But we are looking at other areas. And another component of what we're doing with our practices, again, a bit of jargon, a bit of language, is ghost patients. So patients on our lists that are driving these targets who might not be in country anymore. and particularly we're working with our universities to understand whether we are targeting people who aren't in country anymore. So we kind of started big with big numbers, and we had a centralised model, and Askham Bar has worked brilliantly in terms of access for big numbers, but alongside that we're really kind of driving through smaller numbers just to make sure that that centralized access model that might not be right for some people, we're flexing the approach. So we've talked about pop-up clinics, and we've had them at various sites. We've been into some workplaces to interact with employers where there've been previously high outbreaks. And I just wanted to make a couple of comments, link it back to some of that data. So our learning disability community have really high vaccination rates in the Vale of York, first and second, and those not vaccinated by practice are in single digits. So we're really content that we've worked with those community leaders to try and flex the approach. We've started more work with people with mental illness, particularly serious mental illness, but we still got more work to do with that, and I think we put our hands up to that, and that forms part of a whole range of things that we want to do to make sure that the vaccine programme is like a lead piece of work that helps us to re-engage with some of our communities. So I'll just pause there on the vaccination programme and invite Sharon to talk about COVID.
Can I ask a really quick question before Sharon speaks? The students that potentially have been in York, staying in York, that have had their first jab, might be going back home again.
So there's two aspects to that. Actually, a fair proportion of students stay in York because they don't feel that they've had the university experience, so they're staying. And I mean, I personally would say that our universities and our higher education facilities have had a fantastic offer to the students around supporting them with accommodation and extended accommodation offers. But the national booking system allows you to have your vaccine in 2 places. So I think we've got that covered, notwithstanding issues with computer systems. So I just put my hands up to that just to have that global caveat. But also, as I say, that vaccination approach kind of tried to walk that tightrope with the 8 weeks, which would be in York, and even if they went home when they return in September, it's there or thereabouts. But through the national booking system, that you can have a vaccination in 2 different places.
That's fabulous. That's reassuring to know. Thank you, Steph. So sorry, Sharon, over to you.
Oh no, that's fine. I mean, we need to remember that vaccination is voluntary, and even though, as Steph says, there are huge efforts going on to ensure that everyone is offered a vaccine and that everyone has had a conversation so that they are making an informed choice whether they decide not to take up the offer of a vaccine, but we'll never get to 100%. So I suppose it's just bearing that in mind, really. In terms of
Sharon, I think Sharon, the government's increasing approach though is it's only a suggestion. Just remember who's made it, isn't it?
Yeah. So and if the government goes ahead and makes you have to be fully vaccinated before you're able to enter a nightclub, then maybe we'll start to see that impact on rates as well, but we'll wait and see. In terms of COVID, our case numbers in North Yorkshire and York are still increasing. They're not increasing at the rate that they were previously, so the rate has slowed down. And for York, as of today, our rate has fallen below regional and national averages. That still reflects, for the city of York, over 1,000 new cases of COVID in the last 7 days. So obviously that is still a concern and a significant level of infection we still have. Obviously that means that the higher the prevalence of COVID in our communities, the greater the risk of people then requiring hospital admission due to COVID, and people losing their lives to COVID. And so if rates continue to increase, then we'll start to see increased pressures emerging within the acute trust and across the NHS, actually, due to the level of infection. Obviously, we discussed earlier in the meeting the impacts on the system through staff self-isolating, etc. So we'll end up with a double whammy if cases continue to rise. So we're seeing COVID cases in all age groups, but we are seeing the highest number of cases in younger age groups. So that includes school-aged children as well as younger adults. Younger adults, of course, are now eligible to be vaccinated, and Steph has already talked about some of the work that's going on to target those age groups. Obviously, the government has now announced that vulnerable children over 12 will be eligible for a COVID vaccine once that programme is introduced. But that still leaves us with a large cohort in both, across the Vale of York population, in younger children that will not be eligible for vaccination. And while ever we've got a section of our population that's not protected through vaccination, we still have hosts for the virus to carry on infecting. So we're not out of the woods yet by any means. And so really it's to encourage patients, residents across the Vale of York to continue to follow those COVID safe measures. Okay, we have the freedom in that legal restrictions have been lifted, but we're not free of COVID, and we know that's still with us. So the basic infection control measures around washing your hands regularly with soap and water, using hand sanitizer if you don't have access to soap and water. If you've got coughs and sneezes, catching those coughs and sneezes in a tissue and disposing of that in the bin. Wearing face coverings, it really is expected that patients still wear face masks in healthcare settings, but I'm also encouraging people to continue to wear face coverings in crowded indoor spaces. And then social distancing continues to be important, particularly if you're in a crowded indoor space where perhaps there's poor ventilation and you're with a lot of people that you don't normally come into contact with. Social distancing is still important, and of course getting vaccinated, as we've just talked about. And the campaign that we've just launched is really about people taking personal responsibility for protecting our communities around us, respecting the fact that people have different feelings at the moment. Some people are really excited that there are no legal restrictions anymore, but for some people, particularly those that perhaps have underlying medical conditions, they're very anxious. So, respecting each other's views and being kind to each other. So if you're with a group of people visiting relatives, whatever, they would feel safer if you were to wear a face mask, then please wear a face mask. And if people would prefer you to keep your distance, then keep your distance and, you know, respect and be kind to each other. And that served us well throughout the pandemic, and I'm sure will do. So, you know, really strong encouragement for people to continue those sort of COVID safe behaviours. In terms of hospital, we are seeing an increase in hospital admissions, low numbers at the moment. Obviously, we want to continue to keep those numbers low, particularly as we start to head into autumn, winter. So that's kind of the key message, really. Thank you, Julie.
Thank you, Sharon. That was really interesting, especially around the campaign. And you know, and I think personally, I'd like to have seen a different message coming from our government, and hopefully in the next few days we'll get that kind of information coming our way. I'm sure that's the only right and proper thing for us to be hearing at this moment in time. As somebody who will continue to follow all of the COVID rules and wear a mask and continue to wash my hands, etc., and looking at everyone else, you know, nodding in agreement, I think it's the right and proper thing to do. Thank you, Andrew. Any comments, Andrew?
That was a great message, Sharon. It's a shame we can't televise it. So I just wondered, we've had a few questions now through the LMC, and bearing in mind, I think I know more people with COVID now that all of my clinical colleagues are double vaccinated than I did during the first wave, to be honest. There's been some evidence that the FFP respirator masks are significantly more effective at reducing transmission and also reducing severity of illness. And we're still using the surgical masks as per the IPC that have never been overly convincing as protection, to be honest, but feel even less so now. Can I ask, is there anything that, because we're not going to get any change in national guidance, that seems pretty certain. Is there anything that the CCG can do at all to look into whether there can be some provision of something like FFP masks for primary care?
I mean, I think that is probably a discussion that we can have perhaps at the Health and Care Alliance or at the Infection Prevention and Control Committee. I mean, you're right that there has been a number of studies, including the most recent one from Cambridge, showing that in certain healthcare environments, FFP3 masks undoubtedly provide a better level of protection. The issue with the FFP3 masks, as you'll be aware, Andrew, is that you can't just order one off the internet and use it. They've got to be fitted correctly. And at the moment, there is an issue that fitters are probably sitting in the hospital trust. CCGs don't necessarily have fitters, and primary care don't either. But for me, this is a system-wide issue. It's not just an issue for Vale of York. And, you know, increasingly we work in an integrated way. We would probably want to get a view across North Yorkshire and York practices with, you know, across both CCGs. I mean, I would encourage you to perhaps, on behalf of the LMC, write to both CCGs and perhaps raise that question so that it can be looked at properly. And, you know, public health can obviously support in providing some advice around that. And then it would be a decision for the CCGs to make based on the evidence, really, as to whether it would be something that they would want to support. But certainly, given what you've described and the evidence that is out there, it wouldn't be unreasonable to put that request in writing from the LMC, in my view.
Thank you, Sharon. Thanks.
Thank you, Sharon. Steph, Simon, who could that letter be directed to?
It can come to me. Very early in the pandemic, we did a huge amount of training for fit testing masks. I mean, we probably need to refresh that, but underpinning the request will be the procurement access, as well as training, and then of course the funding of it. So we do need to have that conversation, and I would reiterate what Andrew has said, just for the avoidance of doubt. We have a number, and a growing number, of health professionals who are double vaccinated, who are testing COVID positive. So given that a theme running through today's meeting and previous meetings is the access issues in primary care and other environments, but we're the Primary Care Commission, protecting that resource is absolutely key as we move through these summer months. Simon's got his hand up.
Simon's got his hand up. Yeah. Simon, over to you, and then David, please.
Yeah, just to bring in the dirty subject of money, the CCG has no access to COVID funding now. That was withdrawn relatively early on last year. The acute hospitals do, however. So I think it is a reasonable conversation to have at that alliance board, because that is money that's in the system. It isn't all committed at present, and therefore there's a conversation to be had.
Thanks, Simon. Good to know.
Thank you, Simon. Yes, it certainly is. David, over to you, please.
Yeah, could I just raise the question of, I know in the chat box that Sharon's mentioned about a crisis in adult social care. I just wonder, thinking about what happened in care homes, particularly for the elderly, during the last 12 months, if we're making any special plans for residential care, particularly adult residential care, because it seems to me that we perhaps didn't do enough in the last 12 months for particularly elderly people in residential care. And this is not a personal question, but as a nation, are we making any better plans?
Sharon.
Yes, on the first bit, Andrew, as well as writing from the LMC to Steph on the FFP3 mask issue, if you write to me, I'm a member of the Health and Care Alliance, so I can raise it there. But having something in writing would be helpful. So if you send it through to me as well. In terms of care homes, absolutely, David, there is a huge amount of work taking place jointly across the council and the CCG to support care homes. Many of those deaths occurred in care homes in the earlier stages of the pandemic, where we didn't have the level of knowledge and understanding that we have now. But it's also reasonable, I think, to acknowledge that more of those deaths would have occurred in hospital previously. So, care homes have large numbers of frail elderly people who pre-pandemic were much more likely to die in hospital of COVID or a non-COVID illness. obviously, we've been trying to protect hospital capacity as much as possible through the pandemic. So that means that there have been more people remaining in care homes for end-of-life care. And so that has had some impact on the numbers of deaths that we've seen. What is true, however, is that we now know that we need a whole system approach to supporting care homes. We've learned that as the pandemic has gone on. And so there is a load of work. There's a North Yorkshire and York group that regularly meets. There's intensive support that goes into care homes from the council, from the nursing team, the infection control team within the CCG, the infection control service, and the community infection control team as well is providing lots of support. And support to PPE, support to help care homes do their risk assessments. All of that work is going on, and we always respond whenever there's an outbreak in a care home and go in and do set up an incident management team. The crisis in adult social care at the moment is really caused by staffing. So it runs on a kind of basic level of staff. And at the moment, as we were discussing across the system, there are large numbers of staff across adult social care that are self-isolating, either because they've been exposed to COVID and have tested positive, or they're self-isolating, or caring for children or relatives. And that's really what's causing the crisis at the moment. And because the whole system is struggling, we can't really look to mutual aid. We can't look to the hospital and say, keep patients for longer in hospital and don't discharge them as early, to relieve pressure on adult social care services, not just care homes, but domiciliary services as well. We can't ask the hospital to do that because, of course, they're not in a position to keep people for longer. And so some of the discussions we're having at the moment across North Yorkshire and York, across the system really, is how can we support each other? How can we deploy the resources that we've got really effectively? How can we support each other? And also, now that the new health and social care guidance is out, that staff don't necessarily need to self-isolate if they're double vaccinated and they test positive, is there an opportunity to keep more staff in work and have fewer people self-isolating? So that's the issue for us now. We're not seeing large numbers of COVID patients in care homes. We're doing pretty well controlling the numbers. The crisis is a staffing crisis, really, is what we're struggling with at the moment.
Yeah, thank you. Yeah.
Any more questions or comments? Okay, thank you, everyone. I think that was a really powerful discussion. David, it's over to you, please.
Thanks, Julie. Right, so I'll try and be quite succinct with the clinical waste reports. It's not the most exciting area of primary care. So for background, all practices are entitled to have their clinical waste reimbursed under the premises cost directions. In Humber Coast and Vale, as with most of the country, that's transacted through an overarching contract held by the Commissioner. In the case of Vale or York, all the practices are part of a contract NHS England hold with a company called Stericycle, and that's a legacy PCT contract that's been extended year on year. So NHS England are now looking to progress a nationally led procurement of clinical waste in the next year to 18 months to standardise services. However, until then, contracts need to be put in place with the existing providers. So NHS England are in the process of issuing direct awards to ensure services are in place to provide continuity until such time the procurement can take place. So as the budget for primary medical care is delegated, it was felt more suitable for CCGs to sign the contracts. And it's just worth noting that there's no increased cost to the service upon previous years. And then further to the direct award, NHS England's Clinical Waste Procurement Group are recommending the inclusion of a managing agent to manage the clinical waste contract moving forward. That would have a number of benefits, including potential cost savings, as the contracts will be managed through an expert team and also provide a better service to the practices. The cost of the managing agent to Vale York, based on the number of practice sites, would be 5,847. I haven't been able to confirm the annual cost to the CCG, but I think the clinical waste costs are around about £120,000 per annum. So that could actually result in a cost saving based on the feedback from other areas who already have a managing agent in place. So just for some assurance, NHS England and Improvement North Eastern Yorkshire have already taken the decision to support the direct award and managing agent costs for the community pharmacy patient returned clinical waste. And because North Yorkshire PCC always clashes with this, I've just the same paper's gone and North Yorkshire were supportive, so I thought I'll just drop that in. So the committee is asked to confirm the supportive of NHS England progressing the direct award for it to be signed off when it's ready, and proceed with the addition of a managing agent. So any questions or over for a decision?
Oh, Sean.
Dave, I was just going to ask, does this cover the vaccination sites in terms of collecting the sharps and the clinical waste from the vaccination sites? I know we've had issues there previously.
Generally speaking, they've all been added as additional sites. So for instance, Stericycle have been so stretched that we've actually had PHS collecting some of the waste in this area, but it's been mainly around the community pharmacies where we've had that problem. If it's been a practice site doing the vaccinations, it hasn't been a problem. In the new sites, so like Selby and the Galtrees where PHS have stood in. So it's right. Somewhat separate to that, to be honest.
Yep, thank you.
Thank you, Sean. Any more questions or comments? Steph?
Steph?
Dave, is this sort of a like-for-like service? You're not procuring anything around purple bags? Or
no.
Any of the, no, okay. We're
it's
lacking because
it's
yeah, okay. It's just a perennial issue about sort of reactive cytotoxic waste.
The procurement in the future procurement that NHS England are looking at, there might be options to bring that on as a sort of almost like a subcontract. Okay. Simon?
Yeah, just one second. Yeah, I'm supportive of the recommendations. Thank you, Dave.
Thank you.
Yeah.
Okay, great. Thank you, everyone. And then all the other items in the paper are just for noting. I won't go over all of them, but just to sort of one of them will mention is that there were updates to the GP contractual arrangements for 21-22, and they were published by NHS England and can be found through the web link in the report. It includes details of 2 new enhanced services, the weight management and the long COVID enhanced service. They've been issued by NHS England, and practices have until the 31st of July to sign up. I believe there's only 3 practices in Vale York yet to sign up, so we'll keep pushing them, but no reason to believe we won't have all 25 by the deadline.
Thank you, David. And Michelle, just
happy to take any questions. Sorry, Julie.
Yeah, sorry, I was just going to say to Michelle, if she hadn't got that, everybody agreed with the recommendation, and I think we were quite quick with that one. Sorry, David.
Oh, sorry. No, sorry.
Any more questions or comments for Sean on that? Sean, I'm looking at Sean because I was expecting Sean to come back. Sorry, I was preempting a question. You're on thought today, as usual. Right, thank you, everyone. That brings us to the end of this afternoon's meeting. What I'm going to do is I'm going to look back. You can see me, I often scribble away, don't I? I'm making notes. So what I'll do is I'll put some messages to governing body from us all. If anybody's got anything that they want to say to me about that privately, please drop me an email, and I'm happy to do that. If anybody needs to talk to me about anything we've discussed today, please do the same. And our next meeting is actually September the 23rd, which seems ridiculous, doesn't it? And you just wonder where time goes. But yeah, all I can say is, you know, everybody stay safe, keep hand washing, masks on, social distance, because I certainly want to see you all in September and telling me that you've been hale and hearty. So take care, everyone. If you can grab a bit of sunshine, because I think for some of our colleagues sat here, it might be a late lunch. Thank you, everybody, for today. Okay, take care now.
Thanks
Bye.
all. Take care. Bye.
Bye.
Bye.